today we are dealing with the supine PCNL. Okay. A case obese patient, and there are two stones on both the sides. Right side pain is there, so we are operating right side. When you see here, what is the most important thing you see in this column? Where is the column you identify? This is the liver.
Yes.
After liver, colon is anterior, totally anterior. Colon is not at all there. Where is the rib? So when you come from below up, wherever the first tip comes, this is a 12th rib. If the kidney is there, come from below, wherever first structure comes, that is the tip of the 12th rib. You got the point? Where is it? Here. This tip 12th rib, if the kidney is there, so that you can go below puncture. If it is higher than, if kidney is not seen here, then you have to be intercostal for middle cavitation. So if the kidney rib is there, definitely you can go from the below the rib, because it's an oblique tract.
Yes.
Horizontal, but you can go oblique tract also, as far as lower cavitation. That too, most medial part of the rib you don't go now. As the rib end goes lateral, see the pelvis is there. That also inferior to rib bar, because you will be in the mid-axillary line or posterior axillary line. Posterior axillary line somewhere comes here, at the level 12th rib is there, tip. That means you can go below that. Now coming to the thing is, in supine PCNL, the horizontal puncture will be there. Horizontal. So this depth has not much to do with supine when compared to prone. Because in prone, imagine this is a bag, you will go a little down like this. So between the anterior-posterior depth, if it is more, you have to go vertically down. Then the length of the needle is there. Whereas in supine PCNL, it is horizontal. The kidney to skin distance in the horizontal level we have to see. For that, sometimes you strap like this. People will hold like this, so that skin will be stretched and you will have a straight tract. See, automatically. Now, what is the most important landmark? You know how to draw the posterior axillary line. You know the 12th rib. The lower border is below the 12th rib. That means lower pole will be here. Don't forget about ultrasound. Leave it. This is the iliac crest. So when you feel it, feel the resistance type of the wall. These type of walls does not offer resistance for puncture. Now next is what? 0 degree CM. 0 degree you first put it. Where is the stone? Is it seen? Not seen. Then when you are injecting contrast, everybody should see there. Inject the contrast slowly. Dilute contrast should be injected. Why? If any extra vasation occurs, it is a problem. Slowly you see. See. Can you see the stone? Nicely below. Inject. Where is the ureteric catheter? Yeah. Inject. Can you see the filling defect? But lower pole is not delineated. I am not seeing clearly. Inject more. Inject more. Inject more. Yeah. Now you have waited enough time to see the lower pole or middle pole. We don't know. Now what is the first step? Take the needle, put it on the here. What will you put? Like this. If you want to put this, okay, this is the direction.
Yes.
Calyx is not properly seen, but I am able to see.
Yes.
This is the ideal calyx, where it will come below the 12th rib, as we guessed in the CT scan. This is the correct puncture. If you have doubt, other puncture is like this. This will automatically go way above, because this angle is this side, this angle is this side. So I prefer this. Now one more thing, the distance, this is 2/3 of the needle. Can you measure the length of this by ureteric catheter? That much inside will not go. What is the length here? nearly 15 centimeters. 15 centimeters may not go inside. Now next, where you will select the puncture site? Below, way below the posterior, somewhere here. 2 to 5 in the width. This is obese patient. I am going more posteriorly. So I will go like this here. Okay. Now what I do is I hold like this. See this. I hold like this. I keep it like this. Okay. I go. See. I am going straight. See. Horizontal I am going. See, it is moving or kidney not? Moving. So that means I am touching the parenchyma. Now my aim is to go straight into it. I have gone. I don't know. This is totally horizontal. Single puncture I have gone. The depth inside I have not gone is 15. How much? 7.2. Total length of this. See, total was 15. Here 8 centimeter is outside. What is the total length of it inside? Got the point? So 13 is not inside. Now 30 degree inject contrast. Now you see what has happened. It is slightly lower. That means what? Slightly lower means you are more anterior. If the water doesn't come, what will you do? Little posterior. Don't remove everything. Only half centimeter remove. You go posterior because slightly. Still it may be there also. We never know. So what I do is first I will remove it. If it comes, it's okay. If it doesn't come, what should you do? Keep in same 30 degree. Okay? Keep in same 30 degree and slightly posterior. See, it is moving. More moving, and slightly posterior I have gone. Okay? In 30 degree only. Now I remove it. It is coming. That means I have used only 2 times C-arm and I am much away, obese patient, absolutely no problem. The most important point, how much needle is below. If it is only 1 millimeter below, you go below. If it is 1 centimeter below, take it out and enter from here. You can't adjust like this in supine PCNL. Now what? You got this level, this level. How do you decide? Select one level, move the kidney. If it is not moving, down. If it is moving, that means you have to go down. So this is the most important point in supine PCNL. Obesity is not a major issue. See, now, see directly it has gone into the ureter. Now you dilate and remove it. Now what should we do? As much past the guidewire. Now this is the breadth. See, you see. Now you give me the, hold it. You give me the measurement. Hold it now. 15 centimeters. Now it is coming. See, around 12 centimeters. Generally in prone PCNL, 8 to 9 centimeter you will get it. In supine 2-3 centimeter you will go. But not in the kidney. Outside the kidney. People say that kidney parenchyma is travelled more. No, true Brodel sign. It is almost same. When you wanted to do this surgery, you have to decide whether you wanted to use the pneumatic lithotripter or laser. Now, this thing is passed. So, secret is don't use posterior axial line. Use the rib and way below rib. Start, benefit of doubt, more posterior and come up. That is called gradual ascent technique. Whereas in PCNL, gradual descent. Now, when you rotate, see, when you rotate, first C-arm is not seen. That is the problem. You got the point. Because the length is more. So first you have to bring inside C-arm, then outside C-arm. Little bit movement. Now I am using little bit of C-arm now. See, kidney is moving now. So much moving. If you put hand, kidney will not move, and it will. That's all. Okay. This is too thin. The advantage of this is it will bend along with the guide wire, and it will not kink the guide wire. It will take the root of the guide wire. This is also seen with cobra guide wire. Cobra is also like that. Cobra, what happens? It perforates the rectus sheath. Ultimate aim is what? You are perforating the rectus sheath, not the kidney. For kidney, dilatation is not required. This is only for rectus sheath. See how much kidney is moving. See, that is the problem. See, you can do 1 or 2 times. This is my favorite subject. rectus sheath only, not kidney.
Okay, sir. Okay.
1, 2, 3, 4. What you are doing? Rectus sheath dilatation.
Yes, sir.
That is what which gives the
Maximum.
resistance.
Yes, sir.
Now you give the one more rod. Even you are a beginner, do more this time, this type of dilatation. More. Why?
Patient.
Slowly rectus sheath will make multiple
Dilate.
holes. Now you see. Okay. 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 Like this. 1, 2, 3. Only rectus sheath I am dilating.
Yes, sir.
Not the kidney is not the parenchyma. Parenchyma anyway will get dilated.
Yes, sir.
It is
Soft
soft,
structure.
like a cotton. Whereas rectus sheath is, especially in obese patient, rectus sheath is not a problem. But thick
In
patient,
muscular
you have to do. This is my favorite thing.
Yes, sir.
Rectus sheath
Dilate.
dilatation. Now I will
Central.
central rod. I will keep whatever the dilation. 18 you put the dilatation. See, slowly I am. Whenever you do this, see, before entering the kidney, slowly it entered now.
Yes,
See, now you should dilate like this, not like onto the stone. Like this you should not do.
Yes.
Like this you should not do. Like this you should not do. You should do a little above. That means, see what is happening here. You turn little like this. You go nearer.
Yes, sir.
Yeah. So what is the reason? Now you will inject saline a little bit. Why? See, the method of holding is this. This is fixed.
Yes, sir.
This is fixed. Both. This is a brake. This is the accelerator. See how 1 millimeter also there. It should not be
No.
moving. You should inject saline. What the saline will do? Create the
Space.
space in the
Kidney.
kidney so that your dilator will not hit the
Mucosa. And medial wall of the pelvis.
medial wall of the pelvis. Correct. So now you have to see water here. Can you see the water here?
Yes, sir, coming.
If this water is coming, you are very
Safe. We are
Safe.
in the system.
you are in the system. Now you do this. This dilatation while doing perforation can happen. So you should be careful. Got the point?
Yes, sir.
Left hand should be holding tightly. 22 French and 19 scope. 22 French and 19 scope. See, here rectus sheath is coming. While rectus sheath only the perforation will happen. While hitting the rectus sheath forcibly, like in laparoscopy, if you don't cut the rectus sheath, use the only port, it will happen. You got the point? See, I am pulling back. I am pulling back. You observe my hand. This I am pulling back, that I am going inside. Continuously is putting water. Now see, you should not forget this cutting of the cutting.
Skin.
Cut more than less. And cut the dermis.
Yes, sir.
Don't miss the dermis because the dermis is the most
Structure.
most
Toughest structure of the skin.
toughest structure of the skin. This you can do mini perc also. Is it okay? Now one dilator I am keeping more. Why? Rectus sheath perforation.
Yes, sir.
I have perforated now one step more, so that next ampulla sheath will go easily. Then bleeding will not happen. Ampulla is a big nuisance in supine PCNL. So now see how it goes. Just it will rotate 1, 2, because you already dilated. Now can you switch on the CM? Somebody? Water is coming. You should infuse more water. Now, got the point? You should infuse more water and it should be clear. Water from below, please. I am telling you only water. That's not your job, sister job. You should give water infusion. Now this guide wire usually slips. Immediately is holding. Now water, please. Now normally I suck like this. Why? Clots. And any see, do it. Water is not coming. So when water is not coming, you should see. Slowly. So it is coming now.
Yes,
See,
sir, yes, sir.
that is must. So suck it out. Don't do too much also. Otherwise stone may migrate. Enough. Scope itches. Now this proper recording of this. After this there is no much thing. See now, absolutely there is no problem. You got the point? See, this is the entry of the calyx, and this is the infundibulum, and this is the pelvis. Okay. Now this you pass like this, because most tip of the calyx has not seen. Now you can use the pneumatic. Pneumatic, please. You can use pneumatic. You can use. You make pieces in supine PCNL and at the end take out also, no problem. Always break into pieces and take it out. PCNL is, see, I have broken into center. You got the point? This is called bench breaking. If you make 3 pieces, they will be of equal size and chances of less number of times going into, see, can you see? Center you have to break up the stone. It's a hard stone. You can do powder, but if you do powder it will become close to RIRS. Like this, you make pieces and those pieces will come out. You got the point?
Yes, sir.
Next time you do the case. This time I taught you.
Yes,
Now, if you feel that you have made adequate pieces, rotate and take the grasper and take out. See, the stones are coming into the dependent part. Flush. Yeah. If you take out the guide wire, they will come better. You can take out the guide wire. In supine PCNL, this is a disadvantage and advantage. See, this is actually not exactly calycial because you have not seen properly the calyx. Why? Because the dye was not going. But only thing is, this smaller. It's too big. Doesn't mean that you have gone through the proper tip of. This may not be tip of the calyx, I doubt. But no problem because it is not bleeding. So sometimes, see, it is sometimes you are lucky that bleeding will not be there. But ideally, calyx delineation is must. In this case, if the calyx is not delineated, what will you do? You inject the contrast and then the repuncture if you want the proper calyx, tip of the calyx. You got the point what I am telling, Karthik?
yes, sir.
So, like in ultrasound guided puncture. In this case, ultrasound we have not done. See, this is a disadvantage of pneumatic lithotripter. Right? ఏంది పని చేయట్లేదురా? ఏం ఫోర్సెప్స్ మార్చవా? ఇంక ఇప్పటి నుంచి pneumatic తో if you want to break it is difficult. You got the point? So better is laser. Get the laser, thulium. Because if you make multiple the pneumatic lithotripter, it will be moving. Chalo, give me the laser. Now adequate size to come out spontaneously is done with the laser, but not with the. See, some fragments are coming by themselves. Let them come out as much as possible. Okay? See, they are coming out. Flush. Don't touch this. Okay? See, they are coming by themselves. Sometimes, most of the times, you don't require forceps. Do you have the laser?
Yes.
Yeah. Laser, you should use 500 or 600 micron fiber and make holes. This is possible with thulium fiber. People say it is not a fragmenting laser. Why? It will make a nice drill. What is the aim? See, finished. Now, finished. Now, finished. Come out. See, it is coming out. Next, it's coming out. See, all the fibers. The forceps, laser again. Okay, this is a little big, but it is coming out. This is the advantage of 22. It is your judgment. If you use 12 French, you have to make more powder. And most of the PCNLs, when stone is more than 2 centimeter, what is the ideal?
PCNL largest.
PCNL with a larger sheath. That is my concept. But worldwide, laser, ready?
Same discussion going on Euromentorium.
Yeah, Euromentorium that will go. I say that there is no point. PCNL is a fragmentation surgery.
Yes, sir.
PCNL is not a dust surgery.
Whole concept will be there.
Whole concept will go. See, center you do it. Don't fragment. Don't do like RIRS.
Painting method.
Don't do like RIRS. Do like pneumatic lithotripter. See, they are coming out. Don't make powder. Such a large stone, if you do powder, don't you think some fragments will be migrated and they cause less good result?
Yes, sir.
Here, actually, I am slightly more medial puncture. If you do more medial puncture, your working space will be limited. So it's not an ideal puncture, but we gotten away. No, you could not inject the contrast into lower calyx. Let us see where we can improve. Every case you should analyze where you can flush. Laser. So whenever like this, you break with laser, don't struggle. Spend some time, you go there, don't put water when I am doing it. See how much time it took? 10 seconds. How much struggle you did? 15 seconds. So which is worth? Breaking is the worth. So instead of breaking, if you struggle, you will be unnecessarily getting frustrated. You should not frustrate. So appropriate time you should not feel. And if you do posterior puncture, supine PCNL, the drainage of the fragments will not be that good. Give me forceps. If you done more posterior, more anterior drains better. That you remember. Got the point? Because it is in line with the like these pieces you should remove. See, if you do all this, see, this is not correct. They might have migrated into upper calyx. So that's not good. Nobody likes that. So now I am moving the ampla sheath inside, so that all the fragments will directly open into the mouth. Now here laser usage is little. Your flushing is not transmitted because of the impact. Otherwise, all the fragments might have come. These are the fine points you have to learn. This impaction is good or bad? It is good because small fragments will not go into the. You put sometimes laser can hit the opposite wall here. See, it makes nice big, but under vision it should be done. You should not do left and right in the PUJ like under vision. Now you take the pneumatic lithotripter and break it. See, it immediately breaks. How much time it took now? So they should be complementary. They should be complementary. See, you are making surface irregular and making them into pieces. Small pieces will not break with the this much very well. Which one? Pneumatic. Large pieces better. Large fixed piece better. Moving piece flush. Forceps. Moving piece laser. Fixed piece pneumatic. Fixed piece no problem. And very nearer to the pelvic wall impacted, laser is better. In the sense for breaking the stone. Very small stone also laser is better. PUJ impacted but stone not at all seen, pneumatic is better. Like that you have to chant. Both should be complementary. Pneumatic will stay. Remember.
Yes,
Will you do this with pneumatic or laser? Laser better. This is very important. Keep showing there only. You know, here not much to show. So laser, you keep it in the center and keep on doing that. It will become giveaway. It is not peripheral. See, this is called bench breaking. 3 pieces. See, all the 3 pieces will come. Why you wanted to make 1,000 pieces? Huh?
Yes, sir.
That is wrong, na?
Yes, sir.
You can do it nicely for 1 hour, 2 hours. But what is the big advantage? When you have done perfect puncture, where is the bleeding in this? And nephrons between 12 and 19 will not be much. Otherwise, you do RIRS. This can be done FAMS. But patient doesn't want stent. That's why what we are doing? PCNL. You got the point. See how nicely it is broken, large pieces. And approximate size of the piece also you can decide with the laser. Give me the laser. See, this piece breaking with pneumatic is difficult because it will go into upper calyx, PUJ, and then you are flushing. All things will be there. This is, if you see from distance, it will be, see, in no time, see, finished. Got the point? Got the point what I'm saying? Finished. Now it will come out. So, with this only it is taking this much time. If you do powder, it will take more time. Powder is not the aim in PCNL. Forceps. Now, pelvis, if you do posterior puncture, usually supine PCNL drainage will be less. That you should understand. You got the point? So, you go and then see. Okay? You remove one by one piece. It's a big stone, large volume. Do you agree or not?
Yes, sir.
See, you should not flush when I am manipulating. That is absolutely wrong. You made it to go up. Unnecessarily you made it to go up. When I am handling, you should never do that. No, it has gone in front of. You see, here everything is there and it's unnecessarily you have flushed too heavily. So over enthusiasm is also dangerous. So now that piece I have to catch. Okay. Center. To break in the center. See, why fragmentation is not good with thulium fiber laser? Huh?
Very good.
Very good. What is the problem? Flexible nephroscope ready? Forceps. Forceps. Today I am requiring forceps in supine PCNL mold. No hard and fast rules. So, bleeding absolutely is not there. But tri-prong usage should be careful. Why?
One more time you will not visible.
Visible and you will feel the.
Or you will catch the mucosa more.
Catch the mucosa more. So that is a disadvantage. Now you see all these fragments have to be, because you are flushing continuously, will they go into ureter?
No, sir.
No. So that is the advantage of the supine PCNL, and prone also same. But supine PCNL generally they don't go down. Prone PCNL they go.
So pelvis is little anterior.
Yeah, here it will be anterior.
Yes, sir.
That's why in supine PCNL puncture if it is, see all these you should remove. They will cause, they should not be made powder. Powder if you make, they will form, no, they will form stone again. That is the thing. You got the point? Withdraw the ureteric catheter and go below. See how I am adjusting?
Yes, sir.
I am doing these movements so that stone flush. See how the stone forms coagulum in no time. So what you should do is have patience, go close and nicely you remove like this. Okay? Otherwise they usually pass off in the urine. These things can form nidus for the new stone forming. Now you have to go to upper calyx. See this stone you pushed. Okay, these stones. Now this is dangerous. See, this is the problem with the supine PCNL. See how much fragments. Now can you go this this thing? You can go if you are experienced. So now advantage with this is I can see how the thigh is coming in the way. You show here, thigh is coming in the way. So when you want to go to upper calyx, what will happen? thigh will come up in the way. So thigh should be adducted. You got the point? See how he is holding the nicely ampla sheath. It will come out. These fragments, if you do, who is flushing? Water stop, please. So that common sense should be there. Whenever I am taking out the fragment, somebody, even you should be able to control. See, sister is controlling the. See, stop it. Water, stop it. Yeah, water. If you stop, they will see all the fragments. So here, small fragments have come out by themselves because this is more dependent. So now see how many fragments have migrated to. This will happen classically in a medial upper pole infundibulum. Medial upper pole infundibulum. Now suction. Water flush. Suction please. Flush. Yeah. Suction. So everything you should empty. Okay? Okay. Suction. He is pushing. This is the disadvantage of the going from the lower calyx to upper calyx. It's easy, but who is the obstructing factor? Can you see? Completely cleared. Now can you see the pelvis? Now some more clot, everything is there. Suck it out. Now it is easy. So if this thigh is adducted, you can go all movements. So if you are doing only PCNL, let thigh be adducted. That is the point. Is there small. We will take out. We will have. See, if you do powder, this type of powder sticking is very common. This type of powder sticking is very common, and it will cause stone recurrence. We have seen many times stones will form again. This is a bilateral stone disease. It has to be sent for the. It has to be sent for the stone analysis compulsory. See the mucosa little bit torn here. And now other calyces we have to see. Nothing. See nicely. This is the infundibulum of the middle calyx. This is the pelvis. This is the infundibulum. You got the point? Now it looks better now. Now flush from below. Can you see now clearly? All this mug flush. Yeah. Suck. Okay, leave it. See. Flush. Stent ready. Okay, once wait, flush. Water is not there in this. Okay, that's why it is not coming. Water flow is compulsory, essential. The amount of the fluid taken in supine PCNL will be. See how the stone missed here. It is a calyx. So these are the things you should keep in mind, that as much as possible. See, big stone. Big stone. You should be careful with tri-prong sharp here. Okay? See whether it will come or not, we have to see. It's coming. Anna? Something is problem with all the forcepses. Sridhar, you don't want to buy. This forceps is not functioning. Oh my God. They should be regularly changed because these are all low cost. They will flush forceps. See how much it is troubling. You should not lose patience. See, this forceps is better. Okay? All you need is patience. What is this calyx? This is upper. This is upper. So easily you are going. You are looking down. Upper calyx is down posterior. Thigh is the only problem. Okay? Next is, this is the middle calyx where it was there. See, still stones are there. Fragments are there. So middle calyx are also you are able to go easily. Now I am sucking out. Flush. See again and again. This is middle calyx or not? Middle calyx is also down posterior to inferior calyx, not posterior calyx. This is the inferior calyx actually. Now inferior calyx, any other part if you want to see, this is the anterior inferior calyx. This we could not delineate. This calyx we could not see. You are looking up here.
Yes, sir.
The inferior up calyx. Next, pelvis is isocentric, parallel. See, it is parallel.
Parallel.
Whereas inferior calyx is up. You are seeing up or not?
Yes, sir.
Up. Superficial in the sense anterior. Whereas pelvis and all, just go inside, watch everything. Now you pass the guide wire. And I will take out the guide wire. Try with the, which is more ideal.
Over the guide.
Over the guide wire is more ideal. Push inside. That also you try. Whoever comes first, they will. It is anyway not going. I don't know why it is not going. Sometimes the junction, the soft end will not allow. So better to pass the.
Guide.
It was already there. So guide wire will definitely pass fast. I think you are slipping. You should never pass with that one, white one. That is the ABCD. Pull back and push. Yeah. It has come? No. It is not coming. Then we are in little. This is the pelvis. Yeah, it has come. So I have not seen because it has come posterior to my ampla sheath. Okay? Posterior to my ampla sheath. So you should have vision. Withdraw the ampla sheath and see. Okay? Now this is there. You pass the stent. Now you take out the ureteric catheter. Stent should be cut. Did you cut that?
Yes, sir.
Yeah. Withdraw a little bit. Remove the ureteric catheter. What are you doing? Whether I hold or not, ureteric catheter is out once the guide wire is inside. Hold it firmly. So don't do the C-arm unnecessarily. C-arm should be down by this time. Only one shot should be there. This length is how much? 12 centimeter. You push a little bit here, push a little bit here, but C-arm down. So it is there. You take out the guide wire from this side or that side, no problem. C-arm once only. Okay. Now if you do like, you should be careful. Slowly, you should put into it. Okay? Do you require nephrostomy? Nephrostomy, if you want to put it, you can put it. Now I will put it. Okay? I will come out. I will come out completely. And now what I will do? I will inject the contrast. What will it tell? C-arm? 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 It will tell the tract. And also, see, little medial I have gone. C-arm? Contrast, thick contrast. And it also tells whether the colon perforation is there or not. Because it will produce catheter. C-arm? See, I have withdrawn into the, see, this is the picture. So there is not much inferior calyx. Like this. Inferior is not there. Okay? From the all PCNLs. So you should not feel. How to assess whether applying this? Okay? Whether it will stop in compression for 2 minutes. Every case, some amount of bleeding will be there in 22 French. You should not worry. See, this is the disadvantage of the PCNL. See this small bleeding. You are showing this small bleeding. Now you clean it. Now it is stopped or not?
Stop.
Because when you remove some space will be there now.
Yes, sir.
No, it is not there. You clamp, you will put it for 1 hour, 2 hours. After that you remove. If any problem is there, 2 calyxes only. Upper calyx, middle calyx. If calyx is moving, okay. If it is not going, go down. If it is moving very heavily, go below puncture.
Yes.
Or else up. It is moving heavily, go 1 step up. Always do error on the posterior side and gradual ascent. Then you are very safe. And horizontal puncture is very safe. Bleeding is very less. Thank you.